of getting selected for the sample. মানে আমার কারোর উপর কোনো প্রেফারেন্স নেই, আমাদের 1 লাখ জনের যদি পপুলেশন থাকে প্রত্যেক জনের স্যাম্পলে আসার প্রবাবিলিটি 1/1 লাখ। কারোর প্রতি কোনো প্রেফারেন্স নেই, জাস্ট মানে জাস্ট লাইক ঢিল ছুড়ে দেবো, যার মাথায় লাগবে তাকে তুলো না, এরকম ব্যাপার স্যাপার। দ্যাট ইজ সিম্পল। উইদাউট আগে কেন বললাম, এটাই করা হবে, এটাই আমরা করবো মোস্টলি, কারণ আমরা তো মানুষ নিয়ে কাজ করবো, আমরা তো আর এটা কম কাজে লাগে, কাজে লাগে। রিপ্লেসমেন্টটা কি, আমি যাকে নিলাম তাকে সেকেন্ডবার পপুলেশন করবো না, মানে আমি একটা লোক এলো, একটা পেশেন্ট এলো, তার থেকে আমি কিছু ডেটা নিলাম, সে তারপর চলে গেল, আবার ঘুরতে 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 আবার তার সাথে দেখা হলো, তার থেকে আবার ডেটা নিলাম, এটা আমরা করবো না। আমরা একজনকে একবারই নেবো, তারপর তাকে স্যাম্পল থেকে এক্সক্লুড করে দেবো, তাকে আর কোনোদিনই মানে পপুলেশন মানে তাকে একবার নেবো। আর উইথ রিপ্লেসমেন্ট কি, তার ডেটাও আমি সেকেন্ডবার চাইলেও নিতে পারি। যেমন একটা ধর কিছু और की फिरौती दी दो, तो आई कैन नॉट गारंटी I cannot guarantee that. This type of sampling is called বোঝা গেছে কি, আশা করা যায়। এবার সিম্পল র্যান্ডম স্যাম্পলিং এও কিছু বায়াস আসতে পারে, সেই বায়াসগুলো তাড়ানোর রাস্তা বলছি। সিম্পল র্যান্ডম স্যাম্পলিং এ যেহেতু আমার কোনো হাত নেই, শুধু ধর আমি সবার হাইট নিয়ে স্টাডি করছি, তো যারা লম্বা মানুষ তারাই বেশি স্যাম্পেলে আসছে, এরকম হতে পারে, আমার তো হাতে নেই কিছু। এরকমও হতে পারে যে যারা খুব বেটে তারা আসছে স্যাম্পেলে, হতে পারে, অস্বাভাবিক তো কিছু না। তো সেই সমস্যাটা হোয়াট ইজ স্ট্র্যাটিফাইড। আমাদের পপুলেশনটা ইউজুয়ালি কিছু হোমোজেনাস স্টেটে ভাগ করা থাকে, যেমন ধর আমি যদি ভারতবর্ষের হাইট দেখতে চাই, নিশ্চয়ই এক্সপেক্ট করতে পারি যে এই ধর পাঞ্জাবের এই জনদের একটু হাইটটা বেশি হবে কম্পেয়ার টু আমাদের। বিং রেসিস্ট, এটা ডেমোগ্রাফিক্যালি দেখা গেছে। তো দ্য সোসাইটি পপুলেশন ইজ ডিভাইডেড স্ট্যাটাস, বা আরো ইজিলি বলছি, ধর আমি হাইট নিয়ে স্টাডি করছি, মেয়েদের হাইট তো ইন জেনারেল ছেলেদের থেকে কম হয়, তো সোসাইটি তো এবার আমি কি করবো, এই প্রত্যেকটা স্টেটের মধ্যে গিয়ে আমি র্যান্ডম স্যাম্পলিং করবো, যে ধর আমার ধর 300 লোক দরকার, 500 লোক দরকার, আমি এখান থেকে ধর 100 জনকে নিলাম, এখান থেকে ধর 100 জনকে নিলাম, এখান থেকে ধর 100 জন নিলাম, এখান থেকে ধর 100 জনকে নিলাম, মানে 100 জন মেল নিলাম, 100 জন ফিমেল নিলাম, 100 জন আরো কোনো জেন্ডার, 100 জন আরো কোনো জেন্ডার, এইভাবে নিলাম। এবার তাদের সঙ্গে তাদের ক্লাব করে এবার অ্যানালিসিসটা চালাবো, তাহলে কি আমার পপুলেশনটা আরো হোমোজেনাস হলো। So this is the main theory behind stratified random sampling. Understood? হ্যাঁ, তো এবারে বাই দ্য স্ট্র্যাটিফাইড র্যান্ডম স্যাম্পলিং একটা জিনিস মনে রাখবি সবসময়, ইচ স্টেটা ইজ হোমোজেনাস ইন নেচার, যে মানে কোনো ইন্টারসেকশনও হবে না এবং স্টেটাগুলো হোমোজেনাস হবে, মানে ছেলে এবং মেয়ে স্টেটা দুটো কোনো ওভারল্যাপ করবে না, যারা মানে জেন্ডার একটাই হবে, তার একটা মানুষ একটাই জেন্ডার, একটা মানুষের 10টা জেন্ডার হবে, বা একটা মানুষের 10টা এথনিসিটিও হবে না, তার এথনিসিটি যেটা সেইভাবে তাদের। Our last part, cluster sampling. Cluster sampling is very easy, easier than this. See the time first. Almost the same as stratified sampling. The purpose is entirely different. সেই লিস্টটা যদি আমার কাছে থাকে তবে আমি একটা স্ট্র্যাটিফাইড সিম্পল র্যান্ডম স্যাম্পলিং রান করতে পারি। বা ধর পপুলেশন ইনফাইনাইট, আমার কাছে স্যাম্পলিং ফ্রেমটা আছে কিন্তু সেই ফ্রেমটা নিয়ে আমি কিছু করতে পারছি না, তাহলে আমি কি করব? আমি পপুলেশনটার মধ্যে যেরকম ক্লাস্টার আমার পুরো পপুলেশন রয়েছে, তো আমি একটা স্যাম্পল করলাম তার মধ্যে 50%। এবার that is called cluster sampling. Why is it different from stratified sampling? ওখানে আমার মানে নেচার আমাকে ক্লাসিফিকেশনটা করে দিয়েছে, কিন্তু সেই প্রত্যেকটা ক্লাস থেকে একটা একটা করে আমি মানে পার্টিকুলার নাম্বার করে প্রত্যেকটা ক্লাস থেকে র্যান্ডম স্যাম্পলিং করছিলাম। ক্লাস্টার স্যাম্পলিং এর সমস্যাটা হলো, ক্লাস্টার স্যাম্পলিং হলো আমার হাতে পপুলেশন আমার হাতের মুঠোতেই নেই, আমি বুঝতেই পারছি না কতজন রয়েছে, কে কে রয়েছে, একটা আইডিয়া রয়েছে যে হ্যাঁ 50% যে প্রপোর্শনে এই ক্লাস্টারগুলো ছিল সেই প্রপোর্শনটার ব্যাপারে একটা আইডিয়া আছে, তো সেম হোমোজেনাস একটা স্ট্রাকচারে ছোট স্যাম্পল ছোট ক্লাস্টার বলি, সেই ক্লাস্টারটা তুলে নিলাম, দ্যাট ইজ কল্ড ক্লাস্টার স্যাম্পলিং। গট ইট? এটাও খানিকটা কনভিনিয়েন্ট স্যাম্পলিং এর yet promotes randomness. It is an update from convenience sampling. Hope so. এবার ক্লাস্টার স্যাম্পলিং এ আরো একটা মানে জেনারেলাইজড ভার্সন হলো টু স্টেজ স্যাম্পলিং। আমি পুরো পপুলেশনটার মোটামুটি যতখানি আমি অবজার্ভ করতে পারছি সেই পুরোটাকে এরকম ক্লাস্টার 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 ক্লাস্টারে ভেঙে দেবো। এবার প্রত্যেকটা ক্লাস্টারের মধ্যে যেরকম যেরকম ভাগ হওয়ার কথা ছিল সেম ভাবে ভাগ রয়েছে, ঠিক আছে? এবার আমি এর উপর র্যান্ডম স্যাম্পলিং করবো, যে কোনো একটা ক্লাস্টারকে আমি র্যান্ডমলি তুলবো, তারপরে সেটাকে আমি স্টাডি করবো। আমার প্রথমে হাতের সামনে থাকা ক্লাস্টারটাকেই নেবো, এরকম না, বোঝা গেল? আরো র্যান্ডমনেস বাড়বে, বাট এট দ্য সেম টাইম আমাদের কনভিনিয়েন্সটাও থাকছে, বিকজ আমার কাছে ইন্ডিভিজুয়ালকে দিয়ে খোঁজাতে নেবো কি নেবো না, নেবো কি নেবো না করতে হচ্ছে। দিস ইজ হাউ এভরিথিং ওয়ার্কস। আরো বিভিন্ন রকম স্যাম্পলিং হয়, সেগুলো তোদের সিলেবাসে। আচ্ছা, বোঝা গেছে কি এতদূর? কিছু কি বোঝা গেছে? হোপ সো। যাই হোক, এস্টিমেশন আজকে শুরু করবো না, বা হাইপোথিসিস আজকে শুরু করবো না। শুরু করবো না ওটা। যেটা করতে পারি সেটা হলো একটু নর্মাল ডিস্ট্রিবিউশনের ব্যাপারে আইডিয়া দিতে পারি। নর্মাল ডিস্ট্রিবিউশন হলো যে কোনো একটা ফ্রিকোয়েন্সি ডিস্ট্রিবিউশন, কি জানিস তো? যে কোনো ফ্রিকোয়েন্সি ডিস্ট্রিবিউশন সেন্টার যেটা তার মিনের ইকুয়াল ডিস্ট্রিবিউশন পপুলেশন থেকে আমরা মানে আমি ধরে 1,00,000 জনের থেকে ডেটা নিলাম, 1,00,000 জনের নেওয়ার পর দেখলাম যে এদের মিন বেরিয়েছে 500 সামথিং, বা মিন বেরিয়েছে ধর 50, অ্যাভারেজ ওয়েট ধর 50। আমি দেখবো যে 49.5, 49.2 এই ভ্যালুগুলো বেশি কম্পেয়ার টু সে 10.1, কম্পেয়ার আরো সেটা আরো ছোট হবে ধর 1.2। এই ভ্যালুগুলো বেশি আসছে, বেশি নাম্বার of people have values near 50 or the mean average and it is equally distributed on both the sides. মানে যেরকম এই 50-এর কাছাকাছি এরকম, যেমন এদিকে গেলেও ধর তুই হয়তো আখির কাছে ওয়েটটা কম, মানে নাম্বার অফ পিপল কম, বোঝা গেল? এরকম গ্রাফ যেই ফ্রিকোয়েন্সি ডিস্ট্রিবিউশন ডিসপ্লে করবে তাকে বলা হবে নর্মাল ডিস্ট্রিবিউশন। এবার যদি এস এক্স কি হাইট বা ভেরিয়েবল আন্ডারস্ট্যান্ডিং, হাইট বলছি ওয়েট, বা ভেরিয়েবল আন্ডারস্ট্যান্ডিং। দেখি মিউটা কি, মিন অফ দ্য ভেরিয়েবল আন্ডারস্ট্যান্ডিং। এটা নাম দিলাম ধরো আমি জেড, দিস উইল ফলো আর 0-1 ডিস্ট্রিবিউশন। এটা কি হবে, জাস্ট মিন দেখতে হয়ে যাবে। This is a normal 0. এর কোয়ার্টাইলস এর ভ্যালু, এর পার্সেন্টাইলস এর ভ্যালু আমাদের দেয়া থাকে, শুধু কোয়ার্টাইলস মানে যে কোনো পার্সেন্টাইলের ভ্যালুই দেয়া থাকে। একটা টেবিল হয় স্ট্যান্ডার্ড নরমাল টেবিল বলে, সেই টেবিলটাতে এই সব কটা ভ্যালু দেয়া থাকে, সেইগুলো দিয়ে আমরা টেস্টিং এর স্ট্যাটিস্টিকের ভ্যালুগুলোকে মেলাই। যাক, বোঝা গেছে নরমাল ডিস্ট্রিবিউশন কাকে বলে, কিরকম দেখতে হয়। ইট ইজ সাপোজেডলি দ্য ডিস্ট্রিবিউশন অফ এরার্স। এরার বা বায়াস যেটা হয় সেটাকে বলা হয় নরমাল ডিস্ট্রিবিউশন ফলো করে বা স্ট্যান্ডার্ড নরমাল ফলো করে। বায়াস ফলো করে স্ট্যান্ডার্ড নরমাল, কারণ নেগেটিভ বায়াস আর পজিটিভ বায়াস ক্যান্সেল আউট করে। সেটার উপর স্কেল আপ অরিজিন শিফট করে দিলেই তোর নর্মাল ভেরিয়েবল তৈরি হয়ে যাবে, কারণ সেটা নর্মাল ডিস্ট্রিবিউশন ফলো করে। তো সেই নর্মাল ডিস্ট্রিবিউশনের অ্যাজাম্পশনে আমরা সব টেস্টিং ও হাইপোথিসিস করি, ইউজুয়ালি প্যারামেট্রিক টেস্টগুলো করি।
You will be needing in every day in day-to-day practice, and maybe almost every patient or every alternate patient like that. So, you have to be remain vigilant and very clear with you about this investigation, and this is the basic investigation of hematology. So, today just forget about the reports we used to see with the total count, differential count like this, and most of the labs are now equipped with this counters, I mean maybe automatic, semi-automatic or manual, and reports in your time would be coming in this format. So, get familiar with this type of reports. So, automated and complete blood count, this is simple at present, it has become low cost also, not very costly and available almost everywhere, and this is the person Coulter who is the basic culprit for making the change for you. And there are few pointers you need to know what are the basic errors of this. I will come into what is there in the CBC in next 1 or 2 slides. At the sample, how long you can wait before sending the sample to testing. Suppose you have drawn a slide, how long you should wait, after which or within that period you have to interpret the slide to get a proper report, right. So, RBC and platelets swell up when you keep the sample for a long time, they get damaged and their shape and size alters, giving you the false report. That is why MCV, mean corpuscular volume, it becomes high as you wait for longer period. Mean platelet volume, MPV, that also becomes high because the cell swells up, and platelet count becomes low because they get lysed by that time, like that. So, it is the 3 hours is the maximum waiting time, and for slide maximum waiting time is 1 hour, that we need to know. So, if it is hemolyzed, obviously hemolyzed means RBC is lysed, so RBC count would be low, hematocrit will be low. One very important thing you need to know this concept of MCHC would be high in hemolyzed sample. Why? Because this, when the RBC is lysed, hemoglobin remains in the plasma, and that hemoglobin is falsely interpreted by the machine within the RBC, giving high MCHC. Lipemic specimen, you know, in the blood when lipid component is much more, so this water component is less. It is simply like PCV. So, when the cellular component is more, fluid component is less. So, so similarly, if the lipemic sample, you would have less water compartment, so that leads to falsely higher MCV. Hemoglobin would be high, MCH would be high, all would be high in. So, when there is hyperlipidemia, you have to put caution before judging that report. Cold agglutinin, again it gives false report. There are few issues, few pointers we need to know, and what are there in complete blood count. This is the investigation you need in almost every patient. Hemoglobin and hematocrit, all of you know. RBC count should be there, right. And this RBC indices, I had requested this pathology department here in our medical college to include this red cell distribution with them. They have done that. These are the indices that are indispensable part. These 4 you have to have. There are many more also, and as per the different programming of these counters, they have got different other parameters as well, but these are very basic parameters that has to have in almost every report. Platelet count and mean platelet volume, this is very important, and WBC count. total differential and other things. So, these CBC parameters, Menger index is an calculated parameter. It is not directly got, you do not get it directly, you calculate it. And these are known hemoglobin, hematocrit, when you have completed physiology and part of pathology, you know these indices in the RBC, I mean hematology you have read. What is that Menger index is MCV, MCV is measured in femtoliter, MCV by RBC in millions. That is MCV by RBC in millions is called Menger index. I will come into its interpretation later on. It is a very good indicator or pointer to differentiate between iron deficiency anemia and thalassemia trait or carriers. So, this one I discussed in previous class, if you remember till now, 11, 12, 13, 12, 11 is a formula of cutoff point of anemia, right. 11 is between 6 months to 6 year, 6 year to 14 year is 12 and 13 is adult males, 12 is again non-pregnant females and pregnancy is 11. 11, 12, 13, 12, 11. Get up then get down. And on the basis of hemoglobin concentration, now you grade this anemia as mild, moderate, severe or very severe. Between the lowest cutoff point and 10 is the mild anemia on lab basis. Between the lowest point, whether lowest point is 12, that means between 12 to 10 is mild anemia. Where it is 13, 13 to 10 is mild anemia, like that. Okay. So, between 7 to 10 is the then moderate, 5 to 7 is severe and less than 5 is very severe anemia. That is how you differentiate as per laboratory basis. There are clinical criteria also that we will discuss in our during clinical classes. So, there is a mean corpuscular volume. This is one of the parameters you need to know. What is mean corpuscular volume? It is the average size of RBC, that is all. It is the average size of the RBC. Low MCV, I will come to the parameters later on. Low MCV is called microcytic. Now, you all can understand microcytic, normocytic and macrocytic. Is it clear? So, there are different parameters and according to laboratory there are variations of this MCV cutoff points, which one you will consider as microcytic and which one you will call at macrocytic. Very popular is between 80 to 100, below 80 is taken as microcytic and above 100 is taken as macrocytic. But according to lab there are variations. Say here it is given between 80 to 95. There is one formula also. This is very important because if you are given some MCQ like questions, say whether it is microcytic or macrocytic, this is a 5-year child. So, there you can calculate it like this, say above 84 plus 0.6 into age in year is the upper cutoff point and 70 plus age in year is the lowest cutoff point. That means, suppose a child of 5 years, you are given a MCV of 70. What it will be? Microcytic, normocytic or macrocytic? Child 5 years of age, MCV 70. Why? +70 plus 5, 75. So, is below 70. So, it is microcytic. So, you calculate like that. That is an easy way, dynamic, always any point you can calculate whether it is microcytic, macrocytic or normocytic, right. Newborn, this is a special class, you need to remember all the time. In newborn, MCV is higher. So, macrocytic picture is newborn is physiological. Do not misinterpret macrocytic picture in newborn as abnormal. This is very important. So, it can be measured directly by automated counter or calculated by the formula. like that. So, MCV can be falsely elevated in pediatrics, in adults, everywhere. This is very important one, is that when there is significant hyperglycemia, severe hyperglycemia, particularly when the blood glucose level more than 600, it leads to swelling of the cell and a microcytic picture, and there lysis of the cell as well, but the picture will be macrocytic, but that is false, that is pseudo. So, or presence of agglutinins like autoimmune hemolytic anemia, there also will get the same picture, but that is not a true reflection of blood picture of that patient. So, this is actually you see under microscope. I think you have seen definitely. I will just see that this slide I had shown in last class also. Black arrow here, this smaller pointers, these are indicating of platelets, and this is the normal lymphocyte. You see, occupying the nucleus is occupying almost entire of the cell. That is one of the characters of lymphocyte, and this is the RBC. The central pallor should be 1/3 of the total diameter, that is normal. 1/3 of the total diameter is normal. If it is more, that is called increased central pallor. You define increased central pallor as the central pallor more than 1/3 of the total diameter. So, now different causes of normocytic anemia. Obviously, hemolysis initially will lead to normocytic anemia. So, it may be congenital or acquired, whatever might be. Then acute blood loss and aplastic anemia. These are very important causes of normocytic anemia. Anemia of chronic disease sometimes leads to normocytic anemia, sometimes it is called dimorphic anemia, because chronic disease leads to nutritional deficiency as well. So, it gives picture of the both. Microcytic anemia, this is you are conversant with. Iron deficiency, that is the commonest type of anemia in our country. Thalassaemic syndromes, baby trait, major or whatever might be, and anemia of chronic inflammation, lead poisoning, sideroblastic anemia, all this leads to microcytic anemia, and this is one, this list you have to memorize, right, because this is one question anytime in clinics you may be asked, what are the other causes of microcytic anemia? This is very common question. This is another very common list you need to remember. I have made it very short for you so that you can remember it very clearly. So, with megaloblastic bone marrow and without megaloblastic bone marrow. With megaloblastic bone marrow, that is a true macrocytic anemia that happens in vitamin B12 or folate deficiency only. But all others, aplastic anemia, Diamond-Blackfan syndrome and all these other conditions where you get macrocytic peripheral blood picture, bone marrow remains normal, or bone marrow otherwise indicates disease like Diamond-Blackfan syndrome, that is pure red cell aplasia. There you get different blood picture, but it is not macrocytic. So, here MCV again same thing I have told. There is a slightly enlarged picture. I will show you what is other things. This MCH, mean corpuscular hemoglobin, is the average amount of hemoglobin present in one RBC. You will see MCH and MCHC are very close terms. So, MCH is the average amount of RBC, hemoglobin present per RBC average, and that is why its unit is picogram. That is why its unit is picogram and average value is 27 to 31. Again hyperlipidemia results in spuriously increased reading by counter, giving rise to high MCH. MCHC is the average weight of hemoglobin per unit volume. So, if it is microcytic anemia, sometimes MCHC may be higher. Suppose you get one RBC, suppose this is the ball size RBC. Now, some part of the plasma membrane, I mean membrane of the RBC is lost, and you stitch it up, so it becomes a smaller ball, right? But the hemoglobin concentration remains the same. So, what will happen to MCHC? Per unit volume, MCHC will be higher. That happens in spherocytosis, because in periphery in the spleen, there is lysis of the cell in spherocytosis, and some RBC are regenerated, that leads to spuriously higher MCHC, and that is one of the screening tests for spherocytosis as well. So, MCHC would be high in spherocytosis. So, hyperchronia you call when MCHC is, so MCHC is the percentage, is less than 28 and more than 36 is called hyperchromia. So, high MCHC occurs in a hereditary spherocytosis. It may be in case of severe burns or liver disease or sickle cell, and low MCHC would be found in iron deficiency anemia, lead poisoning, thalassemia syndrome, again the same list, almost same list of microcytosis, right, and spuriously high in hyperlipidemia, hyperbilirubinemia, autoagglutination antibodies, right. When you are interpreting the report, you have to keep in mind why, if there is any abnormality or discrepancy either with the clinical picture or with the other parameters of the CBC, you have to think why this is so, then these questions will come, right. So, red cell distribution width, this is very important criteria. Previously it used to be calculated as whether it is microcytic, macrocytic or normocytic, then what is the MCH. MCHC previously used to be taken as more sensitive criteria than MCH, but later on it was found there are some fallacies. So, red cell distribution width came, it is a marker of anisocytosis, that is different size, different cell lines, one having 70 femtoliter, one having 80, one having 90, that is called anisocytosis. But all the red cells, if it is 70 or 75 or 80 similar, so it is the iso, same cell size. So, different cell size is called anisocytosis, and the marker is red cell distribution width. So, what is the distribution width? Lowest to highest. So, lowest cell size to highest cell size, that is the range of RDW. So, RDW is measured in two ways, one is coefficient of variation. I am not showing you the graph or the bar diagram which is there behind this calculation, that is not needed for you right now, and one is for standard deviation. So, in report you will see maybe RDW CV, RDW SD. So, do not confuse with either of these two. SD is the actual measurement of the cell and CV is the calculated value. So, high RDW helps again in distinguishing nutritional anemia, which may be either iron deficiency, folate deficiency or B12 deficiency, all will have high RDW. RDW would be increased, but you can highly differentiate between iron deficiency and B12 and folate, because they will produce macrocytosis and this will produce microcytosis very easily. And it is again distinguishes between iron deficiency and heterozygous thalassemia, I mean carrier or trait, whatever you may call it, and it can distinguish between B12 and folate with other causes of macrocytosis, as I told you. So, this is RDW is a very important criteria. Usually CV is taken as there are different lab variations again. You see in the very one pertinent point is that in every report you have to see what the laboratory is giving as the reference range, but that you have to accept. Do not put your academy first there, the lab the very reference would be the coming first. So, here normal range is between 11 to 14.5 and MCV 80 to 100, that is the lab reference. Based on that, if RDW is normal and low MCV, it is called thalassemia, and both are normal, so there is no anemia, and high MCV, the macrocytosis, that happens in aplastic anemia. So, in aplastic anemia you will have macrocytosis. If RDW is high and MCV is low, it is iron deficiency. So, in iron deficiency and thalassemia both will have low, both will have low what? Low, speak loudly, bit louder, low MCV. So, thalassemia and IDA both will have low MCV, but in here RDW would be normal and RDW would be high in iron deficiency. So, that helps you to differentiate between a thalassemia trait and iron deficiency anemia. There are few other parameters that will be coming up, and when you will enter in your clinical practice, this will be most likely very common investigation because of thanks to these counters. So, immature reticulocyte fraction IRF, absolute reticulocyte count, reticulocyte hemoglobin concentration, and there are few more in the platelets, mean platelet volume, large platelet, giant platelets, and like red cell distribution width, you will have platelet distribution width PDW as well, and immature platelet fraction or IPF. I will come one or two lines on each of these later. So, this is reticulocyte count, it is stained by a supravital stain. Why it is called supravital? Because the stains cells are stained in living condition. So, that is why it is called supravital. So, now when you stain them in methylene blue or Romanowski stain, what happens? They show remnants of this RNA in a reticulin pattern. That is why they are called reticulocytes. That is the reason why they are called reticulocytes. So, they are again corrected reticulocyte, there are different RPI, reticulocyte index. So, these are different indices that should come in reticular. This is macrocytic polychromic cells in smear. Polychromasia refers to macrocytosis, right, and bluish tinge due to presence of RNA. So, these are actually very early stages of RBC. What is earlier stages of RBC? That is called reticulocytes, right. So, they mature and they turn into the RBC, I mean mature RBC. So, what are the causes of reticulocytosis? Any cause of stress, any cause of stress to the bone marrow which is functionally active will lead to reticulocytosis. So, any severe anemia will lead to reticulocytosis after few days. Hemolytic anemia, any stress, I mean acute hemorrhage or even in the recovery stage of anemia, late pregnancy, high altitude, that leads to hypoxia leading to bone marrow stimulation. So, they will lead to high reticulocyte count. This is how it is calculated, not very important for all of you to know. Absolute reticulocyte count is the absolute or count of that. It is usually reticulocyte count is given in percentage of RBC, and this is the total number of reticulocytes present in the blood. Corrected reticulocyte count is one, say when the bone marrow is in stress to release more RBC because of anemia, because of hemolysis, because maybe a recovery stage of iron deficiency anemia, like that, whatever might be. When they are in stress, they release more and more RBCs. When batches of RBCs are released very rapidly, what happens? More reticulocytes also enter into the blood, but that is not the true reticulocyte count of that patient. So, that needs some certain correction. That corrected value is called corrected reticulocyte count. More than 3% is generally indicative of hemolytic anemia, or actually it is not hemolytic anemia, it is stress to the bone marrow. That is why I said more reticulocytes enter into the blood when bone marrow is in stress. So, that leads to higher RPI. So, RPI more than 3, usually many of the textbooks you will see reticulocyte count more than 2.5% indicate hemolysis. Here they have given 3 as the figure. So, increased reticulocyte count, this is again stress to the bone marrow. This basic thing you need to remember, it may be due to hemolysis, it may be due to hemoglobinopathies that leads to de novo hemolysis within the cell, within the body, then sickle, then membrane defect, and these are different causes of hemolysis. I think you now can remember the etiology of hemolysis, pathies. Can you tell me 3 pathies of hemolysis? Membranopathy, morphological defect, membranopathy, enzymopathy. তাই তো enzymopathy মনে আছে কি আছে? Can anybody tell me one example of enzymopathy that leads to hemolysis? Yes? Yes? G6PD, with G6PD, pyruvate kinase, so these are enzymopathies. So, post hemorrhage again it increases after 3 to 4 days after treating of iron deficiency anemia. These are the different stress conditions when bone marrow releases more and more reticulocytes. Decreased, that means bone marrow activity has to slow down to decrease reticulocyte count. Bone marrow activity has to slow down or RBC fragment, precursor should be less, as happens in Diamond Blackfan and this syndrome. So, aplastic anemia, which may be congenital or acquired, myelodysplastic syndromes, bone marrow infiltration, all this leads to decreased reticounts. IRF, এগুলো বলছিলাম বলবো, immature reticulocyte fraction. Actually, within that reticulocyte count, Coulter can identify the reticulocytes which are still earlier, still nascent, primitive. So, any stress or anything will lead to first change in that fraction, immature fraction. So, that is more sensitive to change in body milieu. So, that is called immature reticulocyte fraction or IRF. Normal value of this is fragmented red cell, normal value is 1 to 7%. IRF normal value is not given here, it is 1 to 7%. So, fragmented red cell or cystocytes, it indicative of hemolysis and microangiopathies, a normal range is 0.03 to 0.5 or 0.6. Fractional iron deficiency, iron stores are normal or even high, but iron is not delivered. You know, for iron utilization you need a protein produced by the liver and that is called hepcidin. So, when the hepcidin is more, iron transport is inhibited, vice versa, it acts reciprocally. So, that is inappropriate hepcidin will lead to body will have iron, but body will not be able to utilize iron because the transport protein deficiency. Reticulocyte hemoglobin, again the hemoglobin content of the reticulocyte, a reference value is 28 to 30 picogram. You just remember the names at least, and immature granulocytes. This is important when you screen a patient for infection. That is usually called, there are many things, Dole bodies and these things, but they are not consistent. What is consistent is the IT ratio, what is called band percentage, right. So, band is the immature or earlier version of the matured lymphocytes, neutrophils. So, it is the ratio of the thinnest part of the nucleus. I will show the picture in the next slide. Between the thinnest part and the thickest part should not be more than 1/3. So, that will call band. When it is a mature neutrophil, it will be much more. One part will be very thin, another one is very thick. So, the ratio would be much higher. And this is important, you need to remember, if neutrophil with lobes, nuclear lobes more than 6, it is called hypersegmentation. When it is 5 or lobes are 5, then to classify as hypersegmentation, it has to be 5% of the total count. So, 5 lobes 5%, 6 lobe no percent. So, that is called hypersegmentation. So, this is the picture you see, this is a band, you see the nucleus, it is almost homogeneous, right. And you see here, see the constriction and see the breadth. So, this is the mature neutrophil. So, that is the difference between band and mature neutrophil. Now, if the segmentation is more, you see here how many segments are there, 1, 2, 3, 4, 5, maybe 5. So, if we got 5, then at least 5% should be there of the total neutrophil count to classify that as hypersegmentation. If it is 6, then no percentage. So, these are the parameters we are speaking of. This is the average value. Different age groups it is given term, then month wise, and this is in 6 to 12 years. So, I have given you the cutoff point of anemia also, and you need to remember these values actually, this MCB, MCH, and these are the things, right. Now, again coming back is the classification of anemia. Now, microcytic hypochromic, previously I had given microcytic, macrocytic and normocytic. Now, it is microcytic hypochromic anemia. This list you have to remember: iron deficiency, thalassemia, chronic inflammation, chronic disease, lead poisoning, copper deficiency and sideroblastic anemia. This you have to remember. Then normocytic with high reticcounts and low reticount. High reticount occurs in spherocytosis, elliptocytosis, all these causes of this hemolysis. This is morphological defect and this is the defect in the shape, and this is the G6PD enzymopathies. And low reticount, obviously bone marrow activity would be low, as happens in aplasia, blood loss. This is important for pediatrics, you will not get in adults. This is called TEC, that is transient erythroblastopenia of childhood. Transient erythroblastopenia of childhood, it is transient, as do not remember, but during that period it shows a picture of aplastic anemia. Diamond Blackfan syndrome, you know, this is the pure red cell aplasia. Macrocytosis, again B12 and folate would come first, and third list in the list would be aplastic anemia. And then it's the liver disease, alcoholism, and MDS is myelodysplastic syndromes. Do you like to do some homework? Yes, okay. So, this is a 9-month girl, exclusively breastfed. Why the term exclusively breastfed is given? Because if it is top fed or fed with the cow's milk, whatever, or teen milk, whatever might be, it leads to chronic hemolysis, blood loss. That leads to anemia. So, exclusively breastfed presents with pallor, 9-month child, and blood picture is given as hemoglobin 6.4. Is it anemic? First question. Is it anemic? Say yes, no. Jore, ekটু jore. Yes. Total count 6,600. Is it normal? What's the normal range? What is the normal range? Jore bolo. 4 to 11,000. Well, 12,000 chalega. Differential count, nothing very significant. MCB 57. Is it normal or low? It is low. So, you are getting anemia, you are getting microcytosis. Let us see. MCH 20. Is it low or normal? It is low. MCHC 30 normal, and RBC count, normal RBC count কত? তাহলে it is low. RDWCB কত? Normal value কত বললাম? 11 to 14. So is it low or no, high? So high RDW with microcytic hypochromic anemia, what it is? Iron deficiency anemia. দেখো তোমরা নিজেরা বলে দিতে পারছো। Would you go for HPLC to find out whether thalassemia is present or not? No, you don't need HPLC. So very good. দেখি কি হচ্ছে, আরে কারেক্ট, এটা তোমরা ঠিক বলেছো, iron deficiency anemia. Why? The cause is given, explanation is given, low hemoglobin. তোমরা বলেছো microcytic hypochromic picture, RBC count decreased, RDW increased. Hope আরেকটা এটা কি হলো? Platelet count, এটা তো খেয়াল করিনি। তাহলে the iron deficiency anemia, it is nutritional deficiency, isn't it? So all there is deficiency of the nutrients, how platelet count would be high? Can anybody explain? This is a very basic question of hematology. Can anybody explain why in iron deficiency anemia you may get high platelet count? Because erythropoietin is not a specific stimulator of RBC production. Because of anemia there is high erythropoietin. Erythropoietin stimulates megakaryocyte production as well. That leads to high platelet count here. চলো আরেকটা রয়েছে রে, ছেড়ে দেবো না বলবো? এটা বলবি? হিমোগ্লোবিন 9.4, 5 years child, is it anemia or not? Huh? Anemia. So 5 year means 6 months to 6 year. What is the lowest cutoff point to call it as anemia? 6 months to 6 year? 11 na 12? Let us come to a consensus. 11? Okay. So 11. So 9.4. 9.4, is it mild anemia or moderate anemia? Mild. Why mild? What is mild anemia? 10 to lowest cutoff point. 10 to lowest cutoff point. So is it mild anemia? Next part is between 7 to 10. So it is between 7 to 10. So it is moderate anemia. So the child is suffering from moderate anemia. From hemoglobin we can tell it. Now see TLC, nothing specific. এখানেও কিছু নেই। Again platelet count only 35,000, না 3,50,000, তার মানে এটা ঠিক আছে। MCB 60 at the age of 5 year, কত হবে 5 বছরে? MCB এর লোয়েস্ট পয়েন্ট কত হবে? কত বলেছি? 70 প্লাস এজ ইন ইয়ার। তাহলে 70 প্লাস 5 75, বিলো 75 it is microcytic, so it is microcytic. MCHC 32 normal. চলো RBC count is normal, RDW এটাও তো নর্মাল। তাহলে এটা কি হবে? হাইপোক্রোমিক মাইক্রোসাইটিক ব্লাড পিকচার উইথ নর্মাল RDW কি হয়? হ্যাঁ, থ্যালাসেমিয়া। আরেকটু বলো, মাইনর ট্রেট। এখনো মাইনর বলে না, থ্যালাসেমিয়া ট্রেট। কারেক্ট ডায়াগনোসিস। ডু ইউ নিড ইলেক্ট্রোফোরেসিস, HPLC? No. So that is the basic requirement of this class. Don't go for unnecessary investigation. That is not needed. Explain how you arrive. Microcytic hypochromic, RBC count increased, RDW normal. Oh, this is Menger index. What is a Menger index? কি বলেছিলাম Menger index একটু আগে? MCV in femtoliter, MCV in femtoliter divided by RBC count per deciliter in millions. তাই তো চলো কত আছে দেখো তো মেজর ইন্ডেক্সটা, ক্যালকুলেট করে দাও, মোবাইল বার করো। এমসিবি মানে 60 ডিভাইডেড বাই 6.14, 60 by 6.14, so it is less than 13, less than 13. So this Menger index and RDW will go side by side. If one increases, other will also increase. So low or Menger index indicates it's a case of trait. So below 13 Menger index, that is one pointer again. Menger index less than 13, it indicates thalassemia trait, right? So this is the total picture given. I am not going into that. Another one, this child received 13 months child received repeated blood transfusion, has got hepatosplenomegaly. তাহলে কি হতে পারে? Repeated blood transfusion, hepatosplenomegaly. So either patient is having hemolysis or is not producing more, that is one secondary aplastic anemia, not primary. In primary you don't get hepatosplenomegaly, right? So here hemoglobin is 3.6, total count 22,600. It's normal, raised, raised. So that indicates something problematic, and hemoglobin is low, severe, very severe anemia. Here one thing, platelet count is only 1,60,000, 1,60,000, borderline low, borderline low. Okay, MCB low, MCHC low, RBC count very very low, RDWCB 23.5. তাহলে এটা কি দাঁড়ালো? So that explains why total count is high. হ্যাঁ, ঠিক আছে, কারো কিছু বক্তব্য আছে? তাহলে তোমরা স্লাইডটা দেখছো না, দেখো দেখিনি একটা কিছু মিস করেছিলাম কিনা। ইয়েস, নিউক্লিয়েটেড আরবিসি, তোমরা কেউ কিছু বললে না? স্যার ওইটা কি, ওটা তো নতুন দেখলাম। So what does nucleated RBC mean? Again immature reticulocyte fraction, IRF, right? So it indicates bone marrow is in stress. So there is something is happening, bone marrow is overactive. That's why total count is high, TLC is high. Clear? Severe anemia, microcytic hypochromic, RBC decreased, elevated nucleated RBC, RDW increased. So that is how you interpret CBC. I am showing how CBC is interpreted repeatedly. I think one more and then we will skip. Time আছে? এরপরে ক্লাস আছে তো? হ্যাঁ, কটা ক্লাস আছে এরপরে? 10টা। হ্যাঁ, আই উইল কুইক, এটা আর দেখাবো না এরপর। 12-year-old boy with progressive pallor, no hepatosplenomegaly, 12-year child, progressive মানে gradually increasing pallor, now presented with a hemoglobin of 5.6. What it is? 5.6, severe anemia, very good. TLC, what is this? COM, that is called COM TLC কে কি বলে জানো? আমি ভুলে গেছি, তোরা একটু মনে করিয়ে দে। লিউকোপেনিয়া, ভেরি গুড, এটা মনে পড়ছে না, এটা সেটা তো অভ্যাস করাতে হয়। দ্যাটস কল্ড লিউকোপেনিয়া। ডিএলসি নাথিং, প্লেটিলেটস 30,000, হোয়াট ইট ইজ? খুব কম আছে। তাহলে এখান থেকে আমরা কি কি পাচ্ছি বলতো? হিমোগ্লোবিন কম, টিএলসি কম, প্লেটিলেট কম। এটা কি বলে বলতো? ইট ইজ কল্ড ট্রাইসাইটোপেনিয়া বা প্যানসাইটোপেনিয়া, তাই তো? তিনটেই কম আছে। তাহলে এটা কি? হাইপোপ্লাস্টিক অ্যানিমিয়া। এরপর আর কিছু লাগবে না। মোর পয়েন্টার ইজ এমসিভি ইজ হাই। কি বলেছিলাম? অ্যাপ্লাস্টিক অ্যানিমিয়াতে ম্যাক্রোসাইটোসিস হয়, অ্যাপ্লাস্টিক অ্যানিমিয়াতে ম্যাক্রোসাইটোসিস হয়, আরবিসি ইজ লো, hemoglobin is also low. So this is a case of tricytopenia or pancytopenia. So different causes of pancytopenia. Don't forget to understand common causes or to remember common causes of pancytopenia is a macrocytosis. I mean B12 folate deficiency. This is a very important cause of pancytopenia. Different infections, acquired or congenital aplastic anemia, then this bone marrow infiltration disease, myelodysplastic syndrome, HLH, hypersplenism leading to peripheral RBC destruction, rarer causes of PNH and storage disease, osteopetrosis, and rare because this MDS is a rare cause, myelofibrosis. There is a fibrotic changes in the bone marrow leading to less production. So all these causes lead to pancytopenia. এগুলো আর করবো না, ছেড়ে দিই। It is mean platelet volume, MPV, normal platelet volume কত? 7 to 11. এটা কিন্তু ইম্পর্টেন্ট, এটা জানতে হবে। যত প্লেটিলেট নিউ রিলিজ হবে, earlier platelets they will have higher size. Gradually they settle down to lower size. So initially they are in the higher size as opposed to RBC. So high MPV কত কখন হবে? Any cause that leads to bone marrow stress will lead to more reticulocytosis and more platelet also. So Bernard-Soulier syndrome and similar rapid turnover of platelets, any cause of hemolysis will lead to this. Low, these two you need to remember, Wiskott-Aldrich syndrome, X-linked thrombocytopenia, they cause less MPV, mean platelet volume less than 7. So when you get a MPV less than 7, think of these two diseases may be present. Immature platelet fraction, granulocytes, reticulocyte, these are the newer terminologies. এটা দেখেন, এটা বলে শেষ করে দেবো। 7-year-old boy admitted with DHF, dengue hemorrhagic fever. তাহলে ডেঙ্গু ফিভারও আছে, আবার ডেঙ্গু হ্যামারেজিক ফিভারও আছে। ডু ইউ নো দ্য ডিফারেন্স? ডু ইউ নো দ্য ডিফারেন্স বিটুইন দ্য টু? ঠিক আছে, তাহলে এরপরে বৃহস্পতিবার ক্লিনিক্যাল ক্লাসে যারা যারা আসবে, এখানে কেউ যদি থাকো, তাকে এটা আমি জানতে চাইবো। দিস ইজ ইয়োর হোম টাস্ক, রাইট? You just read the dengue and then come back, because in dengue what happens, there may be low hemoglobin, sometimes bone marrow depression is there, TLC becomes low, platelet count very low. 4-5 বছর আগে পাপায়া এক্সট্রাক্ট থেকে শুরু করে প্রচুর চিকিৎসা বেরিয়ে গিয়েছিল প্লেটিলেট বাড়ানোর জন্য। প্লেটিলেট কাউন্ট লো, you have to increase the platelets. So that led to WHO bring out the guideline that is, unless there is overt hemorrhage, you don't need to replace platelets in dengue hemorrhagic fever. That adds load to the heart and may lead to more heart failure and other complications, because basic pathology, pathogenesis of dengue is quite different. Platelet count 10,000 and IPF যেটা বলছিলাম 1 to 7% is normal, so 24%. Now question is whether you will transfuse the child or not. কিভাবে ডিডাক্ট করা তোমাদের বলতে হবে না, আমি বলে দিচ্ছি। So you see the hemoglobin is low, total count is low, platelet count is only 10,000, there is a risk of overt hemorrhage. So sometimes clinician may advise blood transfusion, which is not a reason as such. Guideline do not say to transfuse unless there is overt hemorrhage, even in low platelet counts. Anyway, but this is an important pointer, is the IPF is 24%, that is much above the normal reference range. That means immature platelets are appearing in the blood. What does that indicate? bone marrow is regenerating. That means platelet count will come up to the normal value within a short period of time, and you don't need to transfuse right now for platelets. So that's the importance of knowing IPF here, right? IPF যদি 3% হতো, you could have transfused. No low platelets, that means there is no production, and that is low IPF, you need to transfuse. But if the production low platelets with high IPF, that means bone marrow is regenerating, don't transfuse the patients. That will avoid unnecessary transfusions. So thank you.
Good morning, everybody. Hello. Everyone, please try to write and follow the chart. It is the gist of the whole topic. So today my topic is hemoflagellates. Hemo means hemo related to blood. Flagellates means parasite which has flagella. So hemoflagellates. This is the gist of the whole topic. Please try to write this. Please everyone try to copy this. Then I will start. Everyone please, আমি বলে দেবো আরেকটু যেটা পাচ্ছ লিখে নাও। So today our topic is hemoflagellates. Hemoflagellates. Hem word related to blood. Flagellates, that means parasite which has flagella. Okay. Now in blood there are some parasites which are attacking us, and it is lying from a very previous years in world, especially in India. Now these hemoflagellates, in book there are so many pages, but I am trying to keep it in short, which will be beneficial for you to keep in mind. Now this is mainly two types. One is leishmania, another is trypanosoma. Leishmania and another is trypanosoma. Leishmania, can you see? There is Leishmania donovani, Leishmania infantum, Leishmania tropica. Leishmania donovani related to kala jar. Kala in Hindi it is black. Ajar means fever. So mainly it is seen in India in Bihar, kala jar. Have you heard the name kala jar? শুনেছো কালা জ্বর? এটা বিহারে বেশি থাকে and in the sub-Himalayan region. Now this is the causative parasite is Leishmania donovani, which causes kala জ্বর and PKDL, post kala জ্বর dermal leishmaniasis. When kala জ্বর is treated after few years or few months, there is skin lesions. So it is called post kala জ্বর dermal leishmaniasis. It is only the dermal disease. Next, Leishmania infantum. It also causes visceral leishmaniasis. Viscera, that means liver, spleen, these are viscera. So visceral involvement, there is not only skin, visceral leishmaniasis and PKDL, post kala জ্বর dermal leishmaniasis, and Leishmania tropica. Tropical, that is skin disease also. So cutaneous leishmaniasis, CL, and oriental shore. So under Leishmania donovani, Leishmania infantum, Leishmania tropica, these three are called old world leishmaniasis. And then Leishmania brasiliensis, Leishmania mexicana complex, Leishmania chagasi, all these are called new world leishmaniasis. These are the classification. If comes a short note regarding Leishmania, you have to give this classification. Now this brasiliensis is related to cutaneous leishmaniasis and mucocutaneous leishmaniasis and mexicana complex cutaneous leishmaniasis and chagasi cutaneous leishmaniasis plus visceral leishmaniasis. All these are under leishmania. Another hemoflagellate is called trypanosoma, which causes sleeping sickness. The patient or the person is always feeling sleepy. তোমাদের কারো কারো ঘুম পায় সব সময় তো. So this is sleeping sickness, but one person is all the time feeling sleepy. দাঁড়িয়ে দাঁড়িয়ে ঘুমোচ্ছে, বসে বসে ঘুমোচ্ছে, হাঁটতে হাঁটতে ঘুম পেয়ে যাচ্ছে. It is a disease. It is seen in Africa. It is called African sleeping sickness. African sleeping sickness by trypanosoma. Trypanosoma again of two varieties, trypanosoma gambiense and trypanosoma rhodesiense. Both are causing African sleeping sickness. What is the causative vector? All these are vector-borne disease. Fly, that is CC fly, TAC, but pronunciation is CC fly. These are all common questions in the oral table. What is the vector of African sleeping sickness? That is CC fly. And other under hemoflagellate trypanosoma, there is Trypanosoma cruzi. So Trypanosoma cruzi and Trypanosoma cruzi. Under Trypanosoma cruzi, there is disease that is called American Chagas disease. And the causative agent, not fly, it is reduvid bug. This is the oral question. What is the causative vector of Chagas disease? Reduvid bug. Okay. And another trypanosoma, some are non-pathogenic, that are called trypanosoma rangeli. It is non-pathogenic. Another trypanosoma is related to the cattle, not human, that is causing disease nagama. So on the whole, hemoflagellates are two two types, Leishmania and Trypanosoma. Under Leishmania, that is Leishmania donovani, Leishmania infantum, Leishmania tropica, Leishmania braziliensis, Leishmania mexicana, Leishmania chagasi. All these are old world leishmaniasis, all these are new world leishmaniasis. All these are causing VL, that means visceral leishmaniasis, or kala jar, that means black fever, blackening of the whole skin and associated with fever. And PKDL, it is also coming as short note, post kala jar dermal leishmaniasis. That means after completion of the treatment, there is skin lesion. After a few years or few months, there is skin lesion which is called PKDL. So causative vector here, CC fly causing sleeping sickness and red-weed bug causing Chagas disease. And here old world leishmaniasis caused by sandfly, Phlebotomus argentifis. These are very common questions. What is the name of sandfly causing kala jar? That is Phlebotomus group, Phlebotomus argentifis. And of New World, that is Leukemia group. This is all for the chart. Please keep it in mind and try to write this. So hemoflagellates, you can see hemoflagellates are, there is flagellated protozoa is found in the peripheral blood. Example is Leishmania and Trypanosoma. Both are transmitted bite of insect vector. These are the different forms of this Leishmania. This is axoneme. You have to draw the picture. This is the axoneme and whole is called amastigote form. Amastigote form of Leishmania which lies in the body, human body. But in the culture we can found this promastigote form. This is promastigote form. This is amastigote form. Means absence of flagella. There is no flagella. This is the nucleus, this is the axoneme, this is the kinetoplast, this is blepharoplast. So this is the feature which is seen in the human blood, mainly in the RE system or reticuloendothelial system. And in culture we will see this form, that is promastigote form. In case of Trypanosoma, we will see extra form, that is epimastigote form. Here is flagella, you can see there is some attachment of the flagella which is called undulating membrane, and here is no undulating membrane, no attachment, only free flagella. And this is Trypomastigote form. This is the infective form in case of Trypanosoma. What is the infective form of Trypanosoma? It is Trypomastigote form or tricyclic Trypomastigote form. Here is whole body is covered by undulating membrane and there is free flagella. So vector, this is the leishmaniasis, that is visceral leishmaniasis, caused by obligatory intracellular protozoa of the genus Leishmania, and primarily affects the reticuloendothelial system, RE system. Can you tell any cell which is under RE system in blood? Monocyte, you have heard. Okay. So reticuloendothelial system, and who is vector? Vector is sandfly. Name is Phlebotomus argentifis. This is a common question. What is the name of the sandfly causing leishmaniasis? That is Phlebotomus argentifis. Now leishmaniasis clinical forms, that is visceral leishmaniasis VL, post kala jar dermal leishmaniasis PKDL occurs few months, years following visceral leishmaniasis. Cutaneous forms, that is cutaneous leishmaniasis CL, diffuse cutaneous leishmaniasis DCL, leishmania recidivans RL, LR, and mucocutaneous leishmaniasis MCL. I have told old world leishmaniasis. This is old world leishmaniasis, Leishmania donovani, Leishmania infantum, Leishmania tropica, and new world Leishmania braziliensis, Leishmania mexicana, Leishmania chagasi. Okay. So, visceral leishmaniasis found in India and Africa. India and Africa. In India, mainly in Bihar, Jharkhand, and sub-Himalayan region. Epidemiology, in India, you know, one of the worst affected country, as it is mainly occurring in the developing country. India is developing country, so it is worst country which have leishmania, visceral leishmaniasis. And in 2019, about 3,139 cases of visceral leishmaniasis and 821 cases of PKDL reported from India with nil death. There is no death. Maximum Bihar 76% and 52% of the PKDL followed by Jharkhand. This is a life cycle. Life cycle very important, you know. Man and other acquire infection by the bite of female sandfly. Always keep in mind it occurs by the attack of female sandfly, not male. Female sandfly which bites one affected man and taking promasticate form into the its body during blood milk. When sandfly biting a person, taking the parasite within it, and then promasticate again when it after infection of the fly, when fly bites one person, with the biting with the blood, it is entering in the human body. The promasticate form is entering. It is then converted into amasticate form. That means no flagella. So in human body, it is converted to amasticate form. Now these amasticate forms taken in circulation, invade reticular endothelial system, and then it circulates in the body of the human. It goes to the liver, it goes to the spleen, it goes to the heart, etc. Now again another sandfly, when bites that person, takes amasticate form. As amasticate form lies in human, so during blood meal it is again taken these amasticate forms, it is transformed to promasticate form in the gut of the sandfly. Then promasticate migrate to the foregut of the fly, and when it bites a man during blood meal through the biting side, it is entering in the human body. So human body, from the fly, this promasticate form is entering. After entering, it is converted into amasticate form. Pathogenicity. The pathogenicity of the promasticates facilitated by binding of the surface antigens, that is GP63 and LPG, to specific receptor of the macrophage. So on the macrophage there are receptors, on which receptor these GP63 and LPG of the surface protein of that parasite binds. LPG is the principal virulence factor. Now, host immune response. When one APC, antigen presenting cell, that is macrophage, presenting the antigen, that means the parasite, presenting the parasite through the T cells. T cells, what happens? There is two types of reaction. One is Th1 and one is Th2. Via Th1, that is chemical, that is chemokines are released, and via Th2 humoral mechanism is initiated. That means B lymphocytes are stimulated, which will produce a huge number of gamma globulin. So in case of leishmaniasis, after blood test we will find hyper gamma globulinemia. Hello. So I have told Th2 cells activated, they leads to humoral immune response due to increased production of IL-10 and IL-4, which will stimulate B cells. That is polyclonal stimulation of the B cell, which will lead to hypergammaglobulinemia observed in patients developing active visceral leishmaniasis and diffuse cutaneous leishmaniasis. It is also called Kalajor, a Hindi term meaning black fever. That is blackening of the whole skin of the patient, and there is severe emaciation or weight loss. There is severe abdominal bulge during hepatosplenomegaly. Liver ta birat boro hoye jabe, spleen ta boro hoye jabe, and very thin and lean person and with anemia. Okay, so this is the picture, and there is pancytopenia. All kinds of blood cells will be diminished, pancytopenia and hypergammaglobulinemia. These are the all features of this Kalajor. Clinical feature, there is, I have told, fever, splenomegaly, hepatomegaly, lymphadenopathy, hyperpigmentation, that means black coloration, pedioedema, ascites, hematological abnormalities, pancytopenia and hypergammaglobulinemia and leishmanoma. You can see the picture. This is bulging due to splenomegaly, bulging due to hepatomegaly. B is hypopigmented skin changes in PKDL. Hypopigment color is diminished. Hypopigmented butterfly shaped skin in case of PKDL, that means post Kalajor dermal leishmaniasis, and C&D extensive facial nodular change which is called PKDL. This is looking like leprosy. Leprosy moto dekhte hoye jabe. There is ocular lesions also, conjunctivitis and uveitis. Diagnosis, detection on amastigot form in the nodular lesions and by serological tests such as direct agglutination test and antibodies to RK39, and this is important, RK39 antigen positive in most of the cases. So what is the diagnostic procedure? Antibody detection. Antibody detection against antigen. Which is antigen? RK39. RK39, that is recombinant kinetoplast antigen, RK39. This antigen present in the patient, and against this antibody is produced. That antibody is diagnosed by ELISA, a direct agglutination test, complement fixation test, etc. Drug is amphotericin B, drug of choice. Amphotericin B, it is also used in fungal infection. This amphotericin B is the drug of choice, given for 4 months. Now leishmania with HIV co-infection. Leishmania with HIV co-infection. If one patient is suffering from HIV, so if we go for blood test, we can find that there is also leishmaniasis. And in leishmania suffering patient, we will see there is HIV. Virus for HIV is present in the blood. So there is correlation with HIV and visceral leishmaniasis. Now lab diagnosis. Lab diagnosis, there is splenic aspiration, most sensitive test, bone marrow aspiration, most commonly preferred, lymph node aspiration, liver biopsy, peripheral blood in HIV infected people, and biopsy of various organs in HIV infected people. This is the picture, very important picture. These are the amastigot forms. There is no flagella, amastigot, there is no flagella. You can see this is the schematic picture, and in the bone marrow real picture, there is smear stained with GMSA, not Leishman stain. Here we will use GMSA stain. GMSA stain, we can see there is the amastigot forms. This is the picture, schematic picture. This is the original picture. These are the amastigot forms. There are some nucleus and this is the axon, and there is no flagella. Culture, for lab diagnosis you have to go for the culture, that is N medium. This is asked in the examination, and lab diagnosis is very important. Culture medium is N medium, that is Novi, Nicoli and McNeil prepared this medium. Then Skinner's liquid medium, and next antibody detection in serum by ELISA, indirect fluorescence antibody test, direct radiation test, and ICT, immunochromatographic test by using RK39 or RKE16 antigens. In culture, you will see these are the flagellated form. The flagellated form, that is promastigote, not amastigote. In body, amastigote form, there is no flagella. In culture, that means outside body, there is flagellated form. We have to diagnose in this way. This is direct agglutination test. Leishmanian test, Montenegro test indicates good CMI. There is delayed type of hypersensitivity and positive in all stages except active visceral leishmaniasis and diffuse cutaneous leishmaniasis. Animal inoculation, which animal is used? Golden hamster is used. Non-specific test, as there is hypergammaglobulinemia, that can be diagnosed by Napier's aldehyde test. This is old now, this is not used nowadays. Nowadays we go for antibody detection. And there is pancytopenia, which can be diagnosed by complete blood count. Treatment, drugs are pentavalent antimonial, previously called urea-stibamine, and liposomal amphotericin B, miltefosine, paramomycin. So drug is pentavalent antimonials, liposomal amphotericin B, miltefosine and paramomycin. Now, who recommended dose? All these which I already told, those are the who recommended dose, that is amphotericin B and combinations, that is liposomal amphotericin B plus miltefosine, liposomal amphotericin B plus paramomycin, miltefosine, all these are who recommended dose. This is for India, Africa not required for us. And prevention of visceral leishmaniasis is vector control. As vector is biting and transmitting the disease, so vector control is the preventing measure. There is National Vector Control Program, NVBDCP, National Vector Borne Disease Control Program. This is the control program, and it is seen the one plan was accepted, that is accelerated plan for Kala-Jar elimination in 2017. It was done in 2017. Vaccine trial, there is no vaccine available, just it is trial stage. Now trypanosoma, which causes sleeping sickness, African sleeping sickness, positive vector is CC fly, and another is under trypanosoma, that is Chagas disease by redovid bug. Trypanosomes are hemoflagellates, reside in the peripheral blood and tissue in host. There are two types I have told, African trypanosomiasis and American trypanosomiasis. That is African sleeping sickness by CC fly. And American trypanosomiasis, Trypanosoma cruzi, causative agent is agent of Chagas disease. So, Trypanosoma cruzi disease is Chagas disease. and causative vector is redovid bug, not fly, it is redovid bug. There is one thing, one is anterior station, one is posterior station. In CC fly, the fly takes the trypanosoma which is converted into epimastigote, then trypomastigote, and it comes to the suppose it is fly, and here after development of the tryponoma, the tryponoma amastigote form, then it goes to the epimastigote form, then trypomastigote form, which is infective form. When it bites, trypomastigote form is coming out. So it is going to anterior end. So it is called anterior station. In case of redovid bug, what happens? If it is bug, the tryponoma, it is converted into epimastigote form, then metacyclic trypomastigote form, and which comes out as feces. It is coming out with feces. There is peculiar when it bites a person, healthy person, what happens? আমাদের মশা কামড়ালে কি করি? আমরা সেটা ঘষে দিই, ইরিটেশন হয়, তাই তো? So when it bites to take blood meal, there is some feces also there which contains the tryponoma, and we are rubbing it. During rubbing through that biting site with the stool, trypomastigote is entering in our body. So it is going posteriorly, so it is called posterior station. It is going anteriorly by bite, it is called anterior station. So it is the method of rubbing of the organism, rubbing of the feces on the biting site. Infection is occurring in human body. And here CC fly biting, here by feces rubbing. Chagas disease or Trypanosoma cruzi. It is related to the South and Central American countries. It is also zoonotic disease. It may infect dogs and cats. Now causative agent is redovid bug. Redovid bugs feces on the abraded skin. So Trypanosoma cruzi transmitted to man by rubbing of the vector's feces on the abraded skin. So laboratory diagnosis of Chagas disease, there is wet mouth preparation or thick and thin smear, just like malaria. This is the feature, you can see. This is the trypanosoma C-shaped. In Chagas disease, it is C-shaped trypanosoma. This is Trypanosoma cruzi. This is trypomastigate form schematic. This is the original in the blood. You can see C-shaped, inverted C-shaped trypomastigate form in thin blood smear stained with GMSA. So keep it in mind. Here not Leishman stain. Here is GMSA stain is required. And in culture there is flagellated form can be found. And for diagnosis, molecular method can be used, animal inoculation can be done, genodiagnosis. Genodiagnosis, can you tell anyone what is genodiagnosis? Genodiagnosis, jano keu? Diagnosis in the vector. যে ফ্লাইটা ক্যারি করছে, ফ্লাইয়ের ব্লাড নিয়ে আমরা তো হিউম্যান ব্লাড টেস্ট করি, এখানে ফ্লাই যে ভেক্টর ফ্লাইয়ের ব্লাড নিয়ে বা ফ্লাইটাকে ইনসেক্ট করে কেটে তাকে যে টেস্ট করে তাকে বলে জেনো। যেমন ম্যালেরিয়ায় মশাটাকে যদি আমরা টেস্ট করি, মশাটাকে কেটে তার ভিতরে যে ব্লাড আছে সেটা দ্যাট ইজ কল্ড জেনো ডায়াগনোসিস, নট হিউম্যান। ওকে, treatment, benznidazole drug of choice, benznidazole drug of choice, and allopurinol allopurinol given alternatively. So drug of choice is allopurinol. It is also called suramine. And in case of Chagas disease, in sleeping sickness, what happens? This is in the brain. So nervous system is depressed. So patient is always feeling sleepy. In case of Chagas disease, not brain is infected. There is infection in the heart, infection in the different nerves supplying the esophagus and colon. So there is tone is lost. There is mega esophagus, mega colon. Esophagus dilated হয়ে যাচ্ছে, colonটা dilated হয়ে যাচ্ছে. That is mega colon, mega esophagus. And heart, there is arrhythmia. As heart is involved in case of trypanosomiasis, so arrhythmia. তাহলে what is the treatment of arrhythmia? Artificial pacemaker setting is the treatment. So not only a drug, there is pacemaker. You can see supportive treatment pacemakers to manage the arrhythmias and surgery. Surgery for correction of megaesophagus and megacolon. So prophylaxis is prevention of vector. African sleeping sickness I have told, that is Trypanosoma brucei and Trypanosoma rhodesiensis complex. Sleeping sickness causative agent is CC fly. This is the CC fly is the vector. There is some ulcer which is called trypanosomal chancre. What are the clinical features? There is systemic febrile illness and there is remittent fever with night sweats and lymphadenopathy and posterior cervical nodes are commonly involved. পেছনে সার্ভাইকাল নোডগুলো ইনভলভ হয়। আমরা শীতকালে যেমন জ্যাকেট করে পেছনে বোতামগুলো আটকাই, সো ইট ইজ কল্ড উইন্টার বটম সাইন, উইন্টার বটম সাইন। As sleeping sickness, sleeping is related to the brain, so there is invasion of the central nervous system and which leads to sleeping sickness. And at daytime, দিনের বেলা ঘুমাবে, রাত্রে insomnia and restlessness. Laboratory diagnosis, as brain is involved, so we have to take CSF, Shankar fluid, lymph node and bone marrow aspirate. And blood weight mount examination, peripheral blood examination, thick and thin smear. You can see in sleeping sickness, there are the trypanosoma. Trypomastigot, which is the infective form. Lymph node aspirate, also helpful. Antigen by ELISA in CSF and serum. And there is card agglutination test. You have to write the names for lab diagnosis. So card agglutination test, CATT. I have already finished. Now only the last lab diagnosis process I have also told. These are very important for oral sand fly. What is the name of the sand fly? Phlebotomus argentipes. What is the name of the vector in sleeping sickness? CC fly. All these are very short questions frequently asked in the examination. And short note, visceral leishmaniasis, PKDL, all these are short notes. Thank you. This is all.
তাহলে diphtheria is the clinical diagnosis. So what is your causative agent? Then you say কি Corynebacterium diphtheria, right? Name the selective media, one selective media for identification of the organisms. কি আছে এটা? Selective media কি Corynebacterium diphtheria? Loeffler serum slope বা Loeffler agar-ও হয়, ঠিক আছে, বা telluride medium, whatever, যে কোনো আমার এখানে একটা চেয়েছে তাহলে আমরা একটা বলবো, ঠিক আছে। দেন হচ্ছে how do you demonstrate these toxin productions, ঠিক আছে, তুমি এর toxin productionsটা কিভাবে demonstrate করবে। The Corynebacterium diphtheria toxin productionটা there is two methods we can demonstrate. One is a in vivo, one is a in vitro. What is the meaning of in vivo? Right, in living cells what we will demonstrate, that is called in vivo, right? In vitro মানে লিভিং সেলের বাইরে আমরা যেটা দেখতে পাচ্ছি, যেমন অ্যান্টিবায়োটিক সেনসিটিভিটি টেস্ট করছি, দ্যাট ইজ আ ইন ভিট্রো থিং, ঠিক আছে। সো ইন ভিভো, সো উই পুশ দ্য ডিপথেরিয়া ইনটু দ্য গিনি পিগ এন্ড উইল সি দ্য রেসপন্স টু দ্য পিগ, ঠিক আছে। গিনি পিগে এবারে সে মারা গেল, তারা টক্সিন প্রোডাকশনস করছে, বাট দিস ইজ নাওয়াডেজ রেয়ার এন্ড ইট ইজ অবসোলেটেড, ঠিক আছে। আর প্রাণীকে হত্যা করা যাবে না, ঠিক আছে। নাও আমরা কি দেখবো, ইন ভিট্রো। In 1975 এলিক জেল প্রেসিপিটেশন টেস্ট ওয়াজ ডেমনস্ট্রেটেড, ঠিক আছে। কি করা হয়, দেখ একটা ছবি আছে, গোল্লা করে একটা ছবি দেখতে পাচ্ছ, একটা, আরে দাঁড়া রে বাবা, শোন না, তুই জানিস সব, আমি বুঝতে পেরেছি। একটা দেখো পারপেন্ডিকুলার একটা আমার প্রথমে একটা করছে প্যারালাল কিছু লাইনস আছে, রাইট, দ্যাট প্যারালাল লাইনস আর দ্য স্ট্রিকিং অফ আ ডিপথেরিয়া অফ ডিফারেন্ট স্ট্রেনস, ওকে, প্যারালাল লাইনস। দেখ মোবাইলে ছবিটা, সবাই আছো তো গ্রুপে, দেখতে পাচ্ছ তো গোল ডায়াগ্রামটা, আমি ছবি খুব বাজে আঁকি, তো হোয়াট এভার। তো প্যারালাল লাইনস আর দ্য ডিফারেন্ট স্ট্রেনস অফ দ্য ডিপথেরিয়া, ওকে, এন্ড দেয়ার ইজ এ ওয়ান পারপেন্ডিকুলার রেক্ট্যাঙ্গেল, ওটা যাই হোক, ব্যারেল লাগলে ওটা রেক্ট্যাঙ্গেল, ঠিক আছে। তো দ্যাট পারপেন্ডিকুলার রেক্ট্যাঙ্গেল ইজ আ কন্টেনিং আ অ্যান্টিটক্সিন স্ট্রিপস, ঠিক আছে, ওটাতে আমার ডিপথেরিয়া অ্যান্টিটক্সিনস দেওয়া আছে, ঠিক আছে। আর প্যারালাল লাইনে কি আছে, ডিপথেরিয়া স্ট্রেন স্টিকিং করা আছে, এন্ড দ্য গোল সার্কেল ইজ আ মিডিয়া, আ কালচার মিডিয়া, ওকে ফাইন। নাও এবারে কি হবে, ডিপথেরিয়া থেকে কি হবে, টক্সিন প্রোডাকশনস হবে, আর এদিকে কি আছে, ধরো অ্যান্টিটক্সিনস আছে, তাহলে ডিপথেরিয়া টক্সিনস গুলো পালাতে চাইবে, দূরে যেতে চাইবে না যেগুলো আছে। তো দেখ অ্যান্টিটক্সিনস আর ডিপথেরিয়া টক্সিনস একটা লাইন তৈরি হচ্ছে। দ্য ফার্স্ট ইজ দ্য বোথ লাইন আর ক্রস ওভার, ঠিক আছে, লাইনগুলো ক্রস ওভার করছে, এজ গুলো, হ্যাঁ। সো দ্যাট মিন বোথ স্ট্রেনস আর নট রিলেটেড। সেকেন্ডটা দেখ, দ্য এজেস আর জাস্ট টাচ করেছে, স্পার ফরমেশনস, ঠিক আছে, ঠিক আছে, দ্যাট মিন বোথ স্ট্রেনস আর পার্শিয়ালি রিলেটেড, ঠিক আছে। এন্ড দ্য লাস্ট ইজ আ বোথ এজেস আর জাস্ট ম্যাচড, ফিউজড, ঠিক আছে। তো দ্যাট মিনস both strains are related. This is nothing but a Ehrlich gel precipitation test. তোর এখানে যদি 3 নাম্বার কোশ্চেন থাকে what is Ehrlich gel precipitation test, তাহলে এটা আমার আসবে, গট ইট, তাহলে এটা এসে লিখে দেবে, কারো কোনো প্রশ্ন নেই। নেক্সট চার্ট, এটা সোজা। A patient came with a OPD with a complaint of hypopigmented macule over the left foot. Last 1 year with an ulcer over the left toe. On examination, the area was found to have loss of superficial and deep sensation. What is your provisional diagnosis? এটা প্রফেশনাল লেখা আছে, হোয়াট এভার, ছেড়ে দাও। What is your provisional diagnosis? আরে লেপ্রি, মাইক্রোব্যাকটেরিয়াম লেপ্রি, লেপ্রোসিতেই একমাত্র হাইপোপিগমেন্টেড প্যাপুল হয় না, আর আমার ওখানে লস অফ সেন্সেশন হয়, হ্যাঁ, নার্ভ এফেক্টেড হয়, রাইট। And what is the investigation will you advise? Microbacterium লেপ্রির জন্য আমরা কি করি, লেপ্রির জন্য না লেপ্রোমিন টেস্ট আমরা জেনারেলি রুটিনলি এসব করি না, যেটা করি সেটা হচ্ছে মডিফাইড এফবি, ঠিক আছে? হ্যাঁ, অ্যাসিড ফাস্ট ব্যাসিলাই এফবি স্ট্রেন পাঠাই। তোর এই কোশ্চেনটা এইভাবেও দেওয়া যেতে পারে যে একটা আমরা এফবি তোরকে একটা তোর এ করে দিলাম, ফোকাস করে দিলাম, ঠিক আছে? লেপ্রি ব্যাসিলাই মোটামুটি একটু ইলংগেটেড হয়, বাট দেখতে কাছাকাছি একই রকম, ঠিক আছে, মানে টিউবারকুলোসিসের মতোই। তো সেখান থেকেও আমরা ব্যাপারটাকে কোশ্চেনটাকে শুরু করতে পারি, ঠিক আছে? যে দিস পেশেন্ট ইজ কাম উইথ দিস, তো তারপরে আমরা সেখান থেকে স্কিনের বিভিন্ন হাইপোপিগমেন্টেড ম্যাকিউল থেকে টিস্যু ফ্লুইড থেকে আমরা একটা জেডেন স্টেন করেছি, জেডেন স্টেন করে এইটা তুমি একটা অ্যাসিড ফাস্ট ব্যাসিলাই দেখা যায়। আর এটার তাহলে H2SO4 কত পার্সেন্ট ইউজ করা হয়? 5%, ঠিক আছে? তো এই হলো দুটো চার্ট, এরকম আরো অনেক চার্টস আছে। তো নেক্সট ক্লাসে আরো আমি চার্টের সংখ্যা বাড়াবো আস্তে আস্তে, ঠিক আছে? তো সেইগুলো নিয়ে আমরা ডিসকাস করব। তো আজকে মোটামুটি এই দুটো চার্টস
ठीक आइडिया है, ठीक है। एबॉर्शन तो सबको पता ही होगा, ऑब्वियसली एवरीबॉडी नोज व्हाट एबॉर्शन इज इन जनरल टर्म, बट इन ब्रॉड इट हैज मेनी टाइप्स एंड मेनी सिनेरियोस। ओके, so we will go first to the abortion, the exact definition. The definition is the expulsion or the extraction of from its mother of an embryo or fetus weighing less than 500 gram or below the period of viability. Okay, what is the period of viability? That means that fetus is capable of surviving outside the uterus, and that is usually 22 to 24 weeks in foreign countries, but in India, in our country, it is usually 28 weeks. Okay, so in present scenario in our country, we take it as 28 weeks, but for definition and for your reference, you should remember 22 weeks. Okay, and simply say less than 500 gram fetal weight. And the expelled embryo is called as abortus. The word abortion is the terminology for spontaneous miscarriage. मतलब we use it simultaneously, miscarriage or abortion. Both are actually the same. You have to remember two important things: weight less than 500 gram, and second is before the period of viability. That fetus is not able to survive outside uterus. Now we divide abortion into early abortion and late abortion. That is according to the gestation period. If it is less than 12 weeks, then we call it as early abortion. And from 12 weeks up to 20 weeks or 22 weeks, we call it as late abortion or late miscarriage. And the causes are according to early and late miscarriage, different causes are there. So here you can see fertilization has occurred, pregnancy test has become positive. Okay, so from here after 12 weeks we call it as early miscarriage, and from 12 weeks to 20 or period of viability, here we will take it 28 weeks. In foreign country we take it as 22 to 24 weeks. That is late miscarriage. The abortion is one of the cause of bleeding in early pregnancy. There are many causes of bleeding in early pregnancy. We divided it into two parts. First, related to pregnancy state, and second, associated with pregnancy state. Both terms are confusing. First is related to pregnancy state means like abortion, molar pregnancy, ectopic pregnancy, or implantation bleeding. That is occurring due to pregnancy. Okay. And those associated with pregnancy state means that were already pre-existing, that were already present and got aggravated during pregnancy, like cervical polyp, cervical erosion, cervical ectropion. Any malignancy may be aggravated during pregnancy, may cause bleeding PV. Those are associated with pregnancy state. Now the division of abortion, what I was telling you, Shayan, you were telling was mainly the induced abortion part, but it has spontaneous part also. When patient itself present with bleeding PV or abortion, so broadly it is divided into two parts: spontaneous and induced. Spontaneous means it has occurred on its own, and induced means that we have induced it, or that either it was MTP, medical termination of pregnancy, or it was illegal termination of pregnancy. Okay. The spontaneous divided into isolated and recurrent pregnancy loss. Recurrent pregnancy loss is very important topic, but it will be taken separately by mostly I think Dr. Amit Datta. It is a separate topic and very vast and very important topic that will be taken separately. We will be talking here about isolated miscarriage, isolated spontaneous miscarriage. These are divided into threatened abortion, inevitable abortion, complete abortion, incomplete, missed, and septic. We will see the details in further slides. The incidence is overall the normal pregnancies, 10 to 20% of normal pregnancies terminate into miscarriage or abortion. 10% are induced or deliberate. About 75% of abortions occurs before 16 weeks, and of these 80% occurs before 12 weeks. That means main thing is most of the abortion occur in first trimester before 12 weeks. Majority of abortion. That's why we call when patient come to us, we tell her that first trimester is the most important, most crucial period. She has to take rest. She has to take the medicines because the abortion mostly occurs in first trimester. 80% of abortion. What are the etiological factors? These are divided into fetal causes and maternal causes. Fetal causes are mainly genetic, maybe multiple pregnancy or degeneration delay, but it is mainly genetic cause that leads to fetal factors. In genetic factors, there are many. Majority, that is the 50% of early miscarriage, that is before 12 weeks, occurs due to genetic cause. Okay. If patient present with early miscarriage, we can suspect that there might be any chromosomal abnormality or genetic factor involved. So, most common is autosomal trisomy, 50%. Then comes the trisomy 16. You don't have to remember all these details, but just remember that early miscarriage is most important cause is genetic factor, so chromosomal abnormality. Autosomal trisomy is the most commonest, and trisomy 16, then monosomy X, polyploidy, and structural chromosomal rearrangements. 2 to 4% of abortions occurs due to these structural chromosomal rearrangements, mostly translocation, deletion, inversion, ring formation, and many other causes. Now coming on to maternal factors, there are many maternal factors. We will deal with one by one. The first is endocrine and metabolic factors, luteal phase defect, thyroid abnormalities, diabetes mellitus, anatomical abnormalities, cervical uterine factors, cervical incompetence or insufficiency, congenital malformation of uterus, uterine fibroid, intrauterine adhesions. Now coming on to the endocrine or metabolic factors, it accounts for 10 to 15% of abortions. The first is luteal phase defect. What is luteal phase defect? It is actually the deficiency of progesterone in the after conception. As you can see here, and this is the normal pregnancy, but here there is luteal phase defect in the second half after implantation or during implantation. There is deficiency of progesterone. That means there is deficient secretion of progesterone from the corpus luteum, or there is endometrial response is very poor to the progesterone. That's why it affects the implantation of the embryo over the uterine wall, and that may lead to abortion. That is the most important cause over here. And the second comes the hypothyroidism, or hypothyroidism may also lead to early trimester abortion, and diabetes mellitus, of course. Now coming on to anatomical abnormalities, here you can see the first is the cervical incompetence. Here the cervix is closed in normal. In the first you can see there is cervical os is closed in normal pregnancy, but if there is cervical incompetence, the cervical os is open, that is not able to close properly. That may, obviously you can see, that may lead to abortion, that the G-sec can easily come down and abortion can happen. So cervical incompetence is the most important cause in anatomical abnormalities, and mostly anatomical abnormalities lead to second trimester abortion mostly, but it can lead to early trimester abortion, early miscarriage, but it is mostly responsible for second trimester or late miscarriage. Uterine fibroid, any congenital abnormalities of uterus like septate uterus, bicournate uterus, uterus diadelphys, unicoordinate uterus, these all may lead to abortion. And last comes the intrauterine adhesions. Intrauterine adhesions, the most important cause is Asherman syndrome. You will in future, when we will take further topics, we will explain it in detail why it occurs, how we will treat it. But why it occurs, mostly if there is any history of PID, or if any, there is repeated history of DNE, dilatation, evacuation, that may lead to adhesion inside the uterine wall. That leads to that impair the implantation and development of the normal embryo or fetus, and that may lead to abortion. Next comes the infection. Infection accounts about 5% of the abortions. It may cause early as well as late abortion. There is transplacental fetal spread. The different causes are viral, parasitic, bacterial. Viral is the most important. CMV, rubella, variola, HIV all may cause abortion in different. You will read it in detail. Mostly you have read it in microbiology. Different viruses causing abortion early and late trimester. Have you read? Huh? Microbiology class? Acha. They will most probably there, that is dealt in microbiology in detail, and we will also detail virus chapter is different in gynae. We will take it in detail. There is very vast rubella. These are very we call it as dangerous viral infection for pregnancy. Okay, parasitic, bacterial, most important chlamydia and spirochete. Immunological disorder accounts for 5 to 10%. This, the antiphospholipid antibody syndrome. This is the most important cause for recurrent miscarriage, and you will read it detail in recurrent miscarriage topic. What are the different antiphospholipid antibodies? Lupus anticoagulant, anticardiolipin antibody, anti-beta 2 glycoprotein, and there are various immune factors. You have to remember this antiphospholipid antibody syndrome. This is the most important cause. Many maternal medical illnesses like cyanotic heart disease or any heart disease of mother, hemoglobinopathies are associated with early trimester miscarriage. Premature rupture of membrane may lead to abortion. Thrombophilias. APLA or antiphospholipid antibody syndrome was also a kind of thrombophilia, but that was acquired kind, and this is inherited thrombophilia. You have read in pathology, hematology, huh? Okay. Here comes the inherited thrombophilia is the most important, and factor 5 level mutation, protein C deficiency, hyperhomocytidemia, and prothrombin gene deficiency. You don't need to learn all, remember all these, just remember the inherited thrombophilias and APLA syndrome. These are the most important things you have to remember here. These are the common causes. In first trimester, what are the important causes? I told you earlier, genetic factors are the most important in first trimester. Endocrine disorder, that were hyperthyroidism, LPD, and diabetes mellitus. Immunological disorder, APLA syndrome, and infections. Second trimester, anatomical abnormalities mainly causes second trimester abortion, and in that cervical incompetence causes the majority of abortions. if any patient comes to you in second trimester, that is around 12 to 14 weeks, she is having miscarriage repeatedly or recurrent abortion is happening, you have to suspect cervical incompetence, the first most thing. Then Müllerian fusion defects or uterine congenital anomalies, uterine synecdoche, what I told you, Asherman syndrome, that is also known as uterine synecdoche, uterine fibroid, maternal medical illnesses. This table is very important for you. Just in short, you can remember this first trimester and second trimester. You need not remember the detail of all of this. These are the very rare causes, but I have to tell you because trauma, many patient comes in OPD with trauma and they further lead to abortion. Trauma is the important cause, external to abdomen or during abdominal pelvic operations. Okay, any drug intake history, quinine, ergot, or any teratogenic drug taken, any blood group incompatibility, any over distension of uterus like in acute hydroneos that may lead to abortion, and maternal malnutrition. These are very rare causes. Most important here is trauma and drugs. So, what are the features of abortion? Can anyone tell? Patient, what complaint patient will say? Anyone? Simple complaint. Bleeding PV, okay, and pain abdomen, very good. These two are the major complaint, okay. So, majority patient will complain vaginal bleeding, abdominal cramps or pain abdomen, lower back pain, back pain, or reduced symptom of pregnancy. These are generalized. Now we will come on to the individual types of abortion. First is the threatened abortion. What is threatened abortion? You can see the term itself tells threat. That means there is a threat to the life of the fetus or embryo. Okay. The condition in which miscarriage has started but not progressed to a state from which recovery is impossible. That means the abortion process has just started, but it can be reversed, or abortion is complete, that is not sure. It can lead to normal pregnancy, or either it can lead to abortion. Okay. Recovery is still possible. There is hope. Okay, in threatened abortion. So, what patient will present with? Mainly vaginal bleeding PV and pain abdomen. What you said, but here it will be less, very less. Okay. So, pain slight, usually painless, or very slight pain will be there. Bleeding PV will be very slight, just spotting. Patient will complain, I'm having spotting for 2-3 days. On examination, what we will find, the cervical os is closed and uterus and cervix is soft. That is the normal finding of pregnancy. Or there may be slight bleeding PV or trace bleeding PV on PV examination. The main thing is on digital examination, the os is closed. Okay. And the ultrasound is the diagnostic. What we will find in ultrasound? Threatened abortion means pregnancy is live, the fetus is live. Okay, the embryo or fetus is live and cardiac activity is present. Cervical os is closed. This will be the finding in ultrasound examination. That's why it is known as threatened. It has not occurred yet. This is a picture depicting the threatened abortion. This is the GSAC. And slight brain PVs has occurred, but os is still closed, okay, and cardiac activity is still present. How we will manage a threatened abortion when patient presents in OPD with bleeding PV? First and most important thing is bed rest, strict bed rest. We ask the patient to take strict bed rest for at least till the bleeding subsides, or till 1 month, okay. And if she is having any pain, then analgesics or pain relief should be given. And 80%, what is the prognosis? 80% of pregnancies with threatened abortion go on until term. Prognosis is good in majority of the cases. Very few cases ended in abortion. If the fetus is live on USG, pregnancy is likely to continue in over 95% cases. And if pregnancy continues, there is increased risk of preterm labor, placenta previa, and IUGR, intrauterine growth restriction. treatment, what I told, rest and drugs for pain relief. And one important thing is uh, there is questionable role of progesterone. We still prescribe progesterone in OPD basis when patient present with threatened abortion, like she's having slight bleeding PV and there is fetal heart is still present and os is closed, then we prescribe progesterone. Like mostly we prescribe micronized progesterone or in injectable form. And role is questionable, but we do have some papers or research supporting this, but it is not proven yet. But we still prescribe, and we have seen many benefits of progesterone. That's why in OPD basis we still prescribe progesterone, but here I have not mentioned it, but because it is not proven yet. Okay. What is the prognosis? About 2/3 of the threatened miscarriage continues beyond 28 weeks of pregnancy, and in breast it terminates either as inevitable or missed miscarriage. What is inevitable abortion? Inevitable means that cannot be stopped. Okay, it has already progressed to a state from where continuation pregnancy is impossible. Okay. So, what will be the clinical features? The same pain and bleeding, but there is a difference. Pain will be severe pain, colicky pain, abdomen, and vaginal bleeding will be more than threatened abortion. Sometimes there is prior clinical evidence of threatened miscarriage or symptoms of miscarriage which has progressed to inevitable abortion. On clinical examination, when we do PV examination, per vaginal examination, we see dilated internal os, and many times products of conception are felt through the os. And uterine size is approx same as period of amenorrhea. This is the picture showing open internal os, and the abortion process has started, and it cannot be reversed back. That abortion will happen. Okay. What is the management? Management is two important things. First, to accelerate the process and maintain asepsis. General measures, we have to see the control of bleeding. If any excessive bleeding is there, we will give methergin, and if any shock or BP is less, we will start IV fluid therapy and blood transfusion according to the blood loss that has occurred. Before 12 weeks, in early abortion, we do dilatation, evacuation, and followed by curettage in analgesia or general anesthesia. Or we can do suction evacuation or MDA also. Here you can see this picture depicting the dilatation and evacuation or curettage done here. This is uterus, this is the cusp speculum, and this is the dilated. Here this is curettage, and here NV is being done, suction is being done. Okay. After 12 weeks, we don't do directly dilatation evacuation. First, we start oxytocin drip. Okay, we have to speed up the process of abortion by inducing it by oxytocin drip in 500 ml. You need not need to remember all this. Just remember that oxytocin is given after 12 weeks. What is incomplete abortion? Incomplete means that has not completed yet, but the process of abortion has already taken place, but the entire products of conception has not expelled. That means a part of it is still left inside the uterine cavity. The clinical features are the same: vaginal bleeding and pain abdomen. But there is also history of expulsion of fleshy mass. Patient will give history that bleeding হয়েছিল, সঙ্গে কিছু বেরিয়েছিল, মাস মতো বেরিয়েছিল. Patient will give this history, and this is very important. If many times patient takes the photograph of that expelled products, and you can see some fleshy masses there. Okay, or many times you can recognize the embryo also. So there is continuation of pain in abdomen and persistent of vaginal bleeding. On internal examination, uterus is smaller than the period of amenorrhea. There is cervical os is still open, and there is bleeding PV. On USG, the products of conception within the uterine cavity is found. This is incomplete abortion. Some part is still inside the uterus and some part is expelled. And cervical os is open. How will we manage this case? Simple, we have to evacuate, obviously. In earlier abortion, dilatation evacuation as usual is done. In some cases, MBO suction evacuation is also done. This here picture you can see this is using Mbbs syringe. Manual vacuum aspiration syringe is being used. Okay, this is used mostly in remote areas where electric supply is not there. There in health centers, they can use Mbbs syringe. We don't need electrical supply for this. We can manually create vacuum and do the suction evacuation. In late abortion, uterus is generally evacuated under general anesthesia. Why ovum forceps? Why ovum forceps? Because fetal parts are large. They will not come through suction evacuation or ovum forceps exactly. That way, suction is not done early, in starting. First, we do by ovum forceps, we evacuate the fetus, the small parts. Many bone has already been formed. After 12 weeks, the fetus is large. Okay, that's why first we have to use ovum forceps, then blunt curate, and if still some bits are there, then at last we use suction evacuation after 12 weeks. Medical management is also being done. Misoprostol 200 microgram. If patient is not bleeding heavily, a patient is stable, okay, then we can manage first with medical abortion. First, we will give misoprostol 200 microgram vaginally every 4 hours till cervical os is dilated and expulsion has started. Many times it get completed on its own after misoprostol. If any products are still inside, then we will complete it with suction evacuation or dilatation curettage after if medical management fails. So there is medical management and surgical management. Now coming on to complete abortion. Complete abortion is when the products of conception are completely expelled from the uterus. The features there are actually no features as such. Patient will give history that she was having heavy bleeding TB, there was history of passage of fleshy mass, and there was pain abdomen, but which has subsided, bleeding has subsided, and in the examination you will find the os is closed, uterus is much smaller, and bleeding is nil or trace. On TPS or USG you will see the uterus is empty. That will confirm that this complete abortion has already occurred. Now coming on to missed abortion. Missed abortion means the term itself, it was missed. That patient was not aware of this abortion, even the doctor was not aware of this abortion. How you have found out? By doing ultrasound. The fetus with CRL more than 6 mm or more without fetal cardiac activity. When we see this, then we can diagnose that was missed abortion. The fetus is dead and breathing passively inside the uterus for a variable period of time, that is known as missed abortion. Clinical features. Clinical features are usually none because patient was not aware of that abortion. Usually patient will not complain anything. Maybe slight pain abdomen or slight bleeding TB, just that's all. Many times when patient presents late, UPT or urinary pregnancy test or immunological test of pregnancy becomes negative. Cervical os was closed. The main finding is this: the cervical os is closed. There is usually no bleeding TB, and UPT becomes negative in late cases only. Uterus is smaller than the period of gestation. On ultrasound, either you see empty sac or there is absent cardiac activity. Then we say it as missed abortion. What are the complications? Why we want to accelerate the process of abortion, missed abortion? Because the retained conception can lead to sepsis, and it can also very rarely lead to DIC when the gestation age is more than 16 weeks. These are the most dreaded complications, two complications, sepsis and DIC. That's why we want to accelerate the process of abortion in case of late presentation. Management are so the three things: expectant, medical, and surgical. Expectant means that we'll wait and watch and wait for the woman to expel the products spontaneously. Many times patient expel the conceptus spontaneously. There is very interesting thing about uterus that it usually expels what is inside if it is not live. So many times when patient is having abortion, missed abortion, majority of cases this aborted get bleeding PV, get pain abdomen, and it gets aborted. And when many times patient delivers, and after that, if any products of conception or bits of placenta are there, any clots are there, that also uterus expels out. That is the beauty of uterus because it never retains any unexpected or unwanted thing inside it. Inside it. So most of the things by nature it has been done. Majority of things get expelled. But if doesn't, then we have to intervene. That is the process: expectant, medical, and surgical. Expectant is wait and watch. In medical, we give misoprostol, 800 microgram per vaginally, and mostly within 48 hours the conceptus gets expelled. In surgical, the same thing. Below 12 weeks, we do suction evacuation, dilatation, curettage, and above 12 weeks, we will give either misoprostol or oxytocin. Okay, and if any medical management is failed, we will go for surgical evacuation. If you are not able to understand the whole lecture, then this is the gist of the whole lecture. Okay, so here this is there is a sequential chain actually. First, you can see missed. The abortion was missed, the os is closed, okay, and there is no fetal cardiac activity and no vaginal bleeding. This is missed abortion. The second is the threatened abortion. The fetus is live and there is cardiac activity present. Os is closed. There is slight bleeding PV or slight pain abdomen, and fetal cardiac activity is present. The third comes the after threatened, it progresses to inevitable abortion. The os gets open and this is for conception in the process of expulsion. Okay, vaginal bleeding is there, pain is there, and there is dilated cervical os, and the next comes after inevitable comes the incomplete. Incomplete, a part has exited and part is still inside. Vaginal bleeding is there, cramping is there, dilated cervical os is there, and some products of conception are still inside the uterus. This is incomplete. And this is complete, all is already expelled, the os is already closed, there is slight or no bleeding PV, no pain abdomen, and no products of conception inside the uterus. This is the gist of this, mainly gist of this lecture. Okay, you must remember at least this minimum points. Okay. Now comes the next most important topic: septic abortion. Why you need to understand septic abortion in our country, in our country's present scenario? Not in present scenario, it was actually more common earlier when we were in Mbbs and we were doing our PGship. Then this was very common because illegal abortion earlier was very common in India. Okay, many you have must have heard about dyes, local dyes doing DNC locally in aseptic or not maintaining aseptic precautions. That was very common earlier. It has much reduced nowadays, but earlier we used to see many cases. Patient will come with bleeding PV, high grade fever, already perforated uterus with foul smelling vaginal discharge. That was very common earlier, but nowadays it has the incidence has reduced very much. So, what is septic abortion? Any abortion associated with infection or sepsis is known as septic abortion. That means the infection of the uterus or the conceptus is known as septic abortion. Okay. So, what are the main features of septic abortion? First is the fever. Patient may present with chills and foul smelling vaginal discharge, and there will be tenderness or pain abdomen, and whereas uterus is very tender actually on examination. And what are the causes? Most important causes: illegal practices of abortion. Okay. But in our scenario, like presently we are inducing abortion, or in case of spontaneous abortion, very rarely septic abortion can happen. It is not like that if patient is aborting spontaneously that no infection will happen. It can happen, but it is rare. Or if we maintain the asepsis, no infection will occur. Incidence is about 10% of abortions. Majority of cases that I already told occur due to illegal induced abortion, but infection can occur even in spontaneous abortion also. A majority of it is associated with incomplete abortion. Mode of infection mainly anaerobic and aerobic, and most common is mist infection. Anaerobic bacteroid stool, anaerobic streptococci, Clostridium velshae, Tetanus bacilli, aerobic E. coli, Klebsiella, Staphylococcus. You must have read in microbiology in detail of all these organisms, but mixed infection is the most common septic abortion. What is the pathology? In majority cases, organisms are endogenous origin that was already present in vagina, okay, or infection localized to the conceptus. In few cases, it spreads to the parametrium, tubes, ovaries, and pelvic peritoneum. And in about very less rare cases, generalized peritonitis or endotoxic shock occurs. Okay, so actually, this is divided into three grading. That is the grade 1 infection localized to uterus. It is within the uterus. Grade 2, it has spread to the parametrium surrounding the uterus. Grade 2 means it has spread to surrounding uterus. Parametrium, tubes, ovaries, and pelvic peritoneum. Grade 3 is generalized peritonitis. It has spread to whole abdomen, and that has led to endotoxic shock. Patient will come in shock, fever and shock, jaundice or acute renal failure. This is very dreaded complication. Grade 1 is the most common and usually associated with spontaneous abortion. Grade 3 is always associated with illegal induced abortion. Many times when patient in grade 3, there is always a history of perforation, uterine perforation, injury to bowel. That's why it has progressed to generalized peritonitis in most of the cases. What are the clinical features as I told you earlier? There will be chills, fever more than 100.4 degree Fahrenheit, prolonged bleeding TB, Holstein vaginal discharge, chronic pelvic pain, and tender uterus, and unusual or unconsciousness. What are the investigations to be done? High vaginal or cervical swab to be done prior to internal examination. Blood investigation, routine blood investigation, TLC, DLC, blood grouping, urine analysis to be done, and now comes the most important ultrasonography of pelvis and abdomen. If patient is stable and we should do USG. Blood culture, if there are chills and rigors, then we have to do blood culture, serum electrolytes, C-reactive protein, serum lactate. Coagulation profile, of course, because DIC is very common, and plain X-ray if there is suspected bowel injury or perforation, uterine perforation is there, then we have to do plain X-ray. And for X-ray test if there is any pulmonary complication suspected. What are the complications? Immediate complication is obviously hemorrhage. There is illegal abortion. Mostly in older times, local dye used to do abortion using metal instruments that were not sterilized, and they were not expert in doing abortion. They used to do vigorously, and majority of cases perforation used to occur. And after uterine perforations comes the bowel. Next to uterus is bowel. Bowel perforation also used to occur, and generalized peritonitis was very common earlier. The hemorrhage, injury to uterus and adjacent structure, most commonly bowel. Spread of infection leads to generalized peritonitis, endotoxic shock, mostly due to E. coli, DIC, acute renal failure, thrombophlebitis, and all these lead to multi-organ dysfunction and increased maternal deaths. How we will manage a case of septic abortion if a patient visits to you in emergency or ward? First is the hospitalization is the most important. You have to send all the investigation, including the cervical general swab, and we will do the examination to assess the process of abortion if it has completed or not, extent of infection, extent of tenderness or pain. Overall assessment is done and clinical grading is given. What I told you earlier, grade 1, grade 2, grade 3. The principles of management are control of sepsis, remove the source of infection. What is the source of infection? Conceptus that has been getting infected. To give supportive therapy, mostly patient presents with shock. In septic abortion, patient presents with shock, severe anemia, fever. So we have to first stabilize the patient, then proceed with further procedures and to assess the response of treatment if patient is getting better or not. In grade 1, usually we give antibiotics, analgesics, sedatives, and if anemia is there, blood transfusion should be given, and evacuation of uterus should be done within 24 hours of starting antibiotic therapy. If excessive bleeding is there, then we have to urgently do evacuation of uterus. Otherwise, we can delay after if the antibiotic effect has come or not. After that, we can do evacuation. And if patient is bleeding excessively, then we have to do urgently. In grade 2, the same element is there, antibiotics are used and evacuation is done. In grade 3, it is the most dreaded thing. The first and foremost important thing is antibiotic, and we have to give higher antibiotics over there. Mostly we give combination of that is covering anaerobic and aerobic bacteria as well. So we have to give, mostly we give piperacillin tazobactam combination and clindamycin and clavulanic acid combination and metronidazole for anaerobic bacteria. And we have to, for surgical management, we have to do evacuation of the uterus, and many times we have to drain the pus by doing posterior colpotomy. What is posterior colpotomy? In the pouch of Douglas, we just give a nick and drain the pus. And in very rare cases where there is suspected perforation and then like peritonitis, many times we have to do laparotomy. And in laparotomy, we will repair the dent. Many times hysterectomy needs to be done, and any bowel injury present should be repaired at that point. And we have to drain all the infection, any pus present in abdomen, we have to wash the abdomen. That is done in laparotomy. So, first and most important thing is antibiotic and the stabilization of the patient. If any anemia is there, that should be given, IV fluids should be given. These are different antibiotics mostly given. Okay, gentamicin, clindamycin, metronidazole. You don't have to remember each and every name. Just high antibiotics are given. Surgery में what I told you, evacuation of uterus, posterior colpotomy, and laparotomy in case of perforation. Many times patient need to get admitted to ICU, and ICU management is required. Where we require ICU management? If persistent hypertension is there, persistent raised serum lactate is there, any pulmonary edema or renal failure is there, renal dialysis is required, and patient is unconscious. In these cases, we require ICU management. And mostly, if patient is presenting in grade 3 septic abortion, then we have to do ICU management only. What is how we can prevent this? As you are medical students, you should know how to prevent this, or you should at least educate the people or general population when you are giving many attending clinics and attending patients, taking their history. You should educate them about the importance of abortion, safe abortion. Okay, and many friends will call you and tell you, or many relatives will call you and ask you about these simple things, abortion. This is very common in many scenario. Nowadays, medical abortion is very common. So you have to know how to be a good doctor and advise safe abortion. To boost family planning practices, to curb unwanted pregnancy, first ask them to do family planning. provide them contraception, choice of contraception, rigid enforcement of legal abortion practices, and take antiseptic precaution during internal examination and operation in spontaneous abortion. In this way, you can reduce the chances of septic abortion. Okay, the most important thing I want to tell you that the diagram I told you, this is and last septic abortion. These are the gist of this lecture.